Gone through the history of the patient. This was a 45-year-old male who was admitted with chest pain and shock, and patient's renal function was also deranged. Patient had acidosis. Now hold the heart in the anatomical position. Open the right side. Grossly, if you get a myocardial infarction, sometimes you can get a fibrinous pericarditis if there is a transmural infarct. Okay, it's not mandatory to get in all the cases. Moreover, this patient died within about 48 hours, too early, to have a pericarditis to start with. This is a tricuspid valve, which is unremarkable. Pulmonary artery, pulmonary valve. Pulmonary artery should be unremarkable, normal. Now in the left side also there is no valvular pathology as such. You can see the mitral valve. Sometimes in case of myocardial infarction, what can happen? The papillary muscle might get ruptured. Okay, that complication is not here. Now in the myocardium, if you see, in the anteroseptal region, there is a necrotic area which is, having a blackish hemorrhagic look. See? Actually, sections have been taken and the heart is pretty old, so that's why it is very difficult to, differentiate at times. But you can appreciate the alteration in color in the myocardium. Yes, now, if you see this kind of infarction, you have to see the extent of the infarction, and then you have to see the subtending artery. Arteries have been taken out from the bed, and this patient had atherosclerotic occlusion. Now it is very difficult to tell, but once you take a cross section, you will be able to see atherosclerosis. Okay, and there was significant atherosclerosis involving LAD. As such, there is no thrombus formation in the lumen, but this patient had, hemorrhagic areas in the myocardium. And
नेक्रोसिस के एरिया से वो लाइन ही
पूरा वॉल इन्फेक्टेड है ना,
कलर चेंज से
लाइन में ही है, बट दिस इज एन अर्ली इन्फाक्ट. ग्रेजुअली यू विल सी द क्लासिकल चेंजेस विथ हेमोरेजिक rim with softening of base. That comes much later, around 3 to 4 days. Okay, now this is another one case. This belong to the case study. Okay, so it is mandatory to see the heart proper with its complication. Then you have to see the artery also. To see the supplying artery, we give 1 to 2 millimeter cut serially, and we tend to try to see what has happened to the plaque. Usually there is a plaque with either a plaque rupture or plaque erosion with thrombosis. Rarely there can be intraplaque hemorrhage. Now this is another one case where there is, see, in the left ventricular cavity there is infarction, there is thrombus formation. The endocardial cavity is showing presence of thrombus. Irregularity hai na. So this is another one case. This is not of the case study. So again you can see that there is a thrombus formation. Wall is showing some whitish scars also. So this patient had repeated infarction. Thrombus is in the lumen.
The dark one is the infarcted area.
Dark one is the infarcted area.
And the irregular one is
irregular is in the luminal thrombus. Thrombus will be there in the lumen. Okay, the endocardium will be denuded, and on the top of the endocardium you will see thrombus formation. And moreover, why thrombus formation? Because necrotic segment is either dyskinetic or akinetic. If it is akinetic, there will be stasis. So stasis will result in thrombosis. Okay. So this is a complicated one. Okay, this is complicated ones, and you have to see the atherosclerosis of the coronary arteries. Aorta as such shows, see, these are raised fibrolipid plaque.
बिल्कुल भी ऑक्लूजन नहीं कर रहा है.
Aorta में occlusion usually होता नहीं है, but you can see ulcerated, thrombus formation with ulceration of the endothelium. Okay, or denudation of the endothelium. Hold it in anatomical position. What can you see here?
Necrosis.
Fibrinous pericarditis.
Oh.
This is how it looks like. Okay. See, the visceral layer of pericardium is looking rough and shaggy. Okay. Now this hemorrhage in the base may be due to terminal procedure, because when the patient dies, just before the death, patient gets vigorous cardiopulmonary resuscitation. So sometimes there can be hemorrhage near the base. So you have seen this is the external aspect. The surface appears shaggy. Right side, open the right side. This is the fossa ovalis, limbus fossa ovalis, rough part of right atrium. Right ventricle is more or less normal, as is the pulmonary artery.
एट्रियल सेप्टल डिफेक्ट था
No, इसमें नहीं था.
वो फोसा ओवलिस कैसे
नहीं, फोसा ओवलिस, लिम्बस फोसा ओवलिस था. एट्रियल सेप्टल डिफेक्ट आपको पिछले हफ्ता दिखाए थे ना.
नहीं मतलब
इसमें नहीं है. इसमें दिस इज द aortic valve. Left ventricular cavity is mildly dilated, otherwise it's within normal limit. The main feature of this is fibrinous pericarditis. Can you make out, all of you?
Yes, ma'am.
Okay.
इसका रीजन क्या?
Fibrinous pericarditis can be due to uremia. Okay. It can be as a result of myocardial infarction. Here it is not there. Maybe the patient had uremic pericarditis. Okay.
इन्फेक्शन से कैसे होगा?
Transmural infarction is localized. You will be able to see infarction in the wall, and on that area there will be an area of fibrin deposition. Okay. This is due to hemorrhage. Probably then hemorrhage is towards the base, the inferior surface. Probably this is due to cardiopulmonary resuscitation. Hemorrhagic pericarditis you get commonly with tuberculosis, tumor, and sometimes bleeding diathesis. Okay.
मैम अगर पेरिकार्डिटिस होगी तो कैन बी से ट्रांसम्यूरल इन्फार्क्ट है?
नहीं, उसमें तो अंडरलाइंग इन्फार्क्ट नहीं दिख रहा है ना. यू हैव टू सी द वॉल आल्सो फॉर इन्फार्क्ट. ओके. जस्ट पेरिकार्डाइटिस विल नॉट मेक इट एन इन केस ऑफ इन्फार्क्ट. ओके. Here what can you see? Right atrium, unremarkable. Right ventricle, pulmonary right ventricle, unremarkable. You come to the left side, there is a VSD.
यस
Oh, wow.
In the membranous portion there is a VSD.
छोटा
This one.
मैम इधर ओके
ये aorta है ना, इसमें some part is due to cut, but there is a VSD.
अच्छा
Okay.
न्यूबॉर्न होगा यार, फीटल हार्ट में थोड़ी ना लिखा है, फीटल हार्ट है.
Again hold it in anatomical position.
न्यूबॉर्न हार्ट होगा.
See the right side.
Neonatal.
This is the fossa ovalis, which is the site of ostium secundum type of ASD. Okay, this is the limbus. Okay, now this is the right ventricle. Pulmonary artery is normal.
Hypertrophy.
Hypertrophy इतना नहीं है. This is the aorta. Aorta is showing atherosclerosis. Okay. Atherosclerosis you have to read quite extensively, including its pathogenesis, you know. What are the predisposing factors for atherosclerosis?
Smoking, hypertension.
At least 4 you will be able to tell, no? Hypertension, smoking, hypercholesterolemia, and diabetes mellitus. In diabetes mellitus, the another one problem is many times because of neuropathy, there may be painless myocardial infarction. Okay. Hold it in anatomical position, externally unremarkable. Right side. This is the fossa ovalis limbus. This is the tricuspid valve, unremarkable. This is the pulmonary artery, unremarkable. Where is the problem then? See, left atrium is dilated. There is thickening of the mitral valve with caudal shortening. Okay. Aortic valve is not involved. So this is a case of mitral involvement in chronic rheumatic heart disease. Mitral valve involvement in chronic rheumatic.
mitral valve सिर्फ rheumatic heart disease से ही और कोई
नहीं, mostly it is 99% is rheumatic in origin. Very rarely there can be congenital parachute-like valve. Sometimes there can be mitral stenosis due to use of some anorexigenic agent or mediastinal irritation. Those are distinctly rare. Commonest cause is post-rheumatic. Here I am trying to see what exactly is there. This is the right side, unremarkable. This is the pulmonary artery, unremarkable. Mitral valve is not showing any obvious commissural fusion, but there is in the anterior leaflet there is mild thickening that is due to hemodynamic effect, because it is close to the aortic valve. Anterior valve leaflet sometimes get hemodynamic changes. You see the chordae tendineae, they are quite long and slender. They are actually normal. Here you can see some blackish discoloration, here also in the wall. Probably this patient had a myocardial infarction, and we have to take a block from that to confirm, because these specimens are pretty old, so there is a difficulty at times to tell about the pathology, but one must look for pathology quite minutely, otherwise you will miss this kind of discoloration. And there is atherosclerosis also, and in such a case it is mandatory to look for the artery also. Where does the LED go? How does LED goes? In the anterior interventricular groove. The circumflex is in the left atrioventricular groove, and the right coronary goes to the right atrioventricular groove. So you have to just make serial sections to see whether it is occluded by atherosclerosis or not, and if there is occlusion, what is the percentage of occlusion. Okay. Right side, there is a patency. I hope it is not artifactual. Seems to be artifactual. It is not within the fossa ovalis. Okay, it must be a neck. The tricuspid valve is unremarkable.
What is this?
Which one?
This hole.
This is the opening of coronary sinus. This one, na?
This one.
These are Thivesian veins.
Okay.
Opening of Thivesian. This is the coronary sinus. No, tricuspid valve also little thickened. Okay. Now, whether this is organic thickening or due to hemodynamic effect, that we have to see under microscopy. There is no distinct commissural fusion. The margin seems to be little thickened. The pulmonary valve is normal. What has happened to the left atrium? Dilated. And see, the valves are thickened, the margins are rolled, the commissures are fused, the chordae are thickened and shortened, and mitral valve is involved, aortic valve is paired. So what is the diagnosis? Rheumatic heart disease with involvement of the mitral valve.
Can we see the vegetation?
Vegetation नहीं है. Vegetation will be there in acute rheumatic fever or in case of activity. Vegetations can be there. Vegetations can be infective, can be non-infective. Non-infective vegetation you will see of acute rheumatic fever. They are usually small pinhead size along the line of closure. Okay, and if in case of infective endocarditis, they are big, they are bulky, friable vegetation on the valve surface. Okay, the vegetations are not there. The aorta is normal. Okay, you should